Hello everyone. Today we're gonna do surgery, some small topics. That is mainly systemic surgery. We are mostly done with the general surgery, important topics. So in eye we see mainly amblyopia, which is very important. You can say it is vision impairment, which is caused by interference with processing of images by the brain, and it can occur during the first 6 to 7 years of life, like in childhood. And the most common thing that child present with is strabismus. We also called it wandering eye. It keep on wander. And the child will see two images overlapping each other, and if it is not corrected in the early age, it can lead to permanent blindness, cortical blindness of the eye which is suppressed. And so we had to treat in early years. So that was the main thing about amblyopia. Sorry for the delay. So next is strabismus. We already know what strabismus is. We can verify it by showing the light from a light comes from the different areas of the cornea in each ear, and it should be surgically corrected whenever it's diagnosed, so that we can prevent the formation of amblyopia. And it's possible that they don't have it in early years and can develop in the early later, very later. And it is exaggerated by the convergence. It has exaggerated convergence, which is caused by refraction difficulties. So we can give the corrective glasses to resolve the problem there itself. But the true strabismus never resolves spontaneously. Now there is also a very common thing that we find in children, that is with retinoblastoma, that is white pupil, we say white reflex. And it's kind of ophthalmologic emergency, and it is caused by it can be caused by like a congenital cataract due to like rubella or other infection, and it should be urgently addressed so that we can prevent the amblyopia. So this is the main things that happen in the child that we correct surgically: amblyopia, strabismus, and retinoblastoma. We treat the cancer. And if retinoblastoma, I would add some things like it's a leukocoria, vision is decreased, and it develops from the retinal cells, immature retinal cells, and most common eye cancer in the child. And it mainly affect with 50% cases are due to RB gene defect and chromosome 3. And if I can say some things about congenital cataract, that is, it can be unilateral, can be bilateral. So 10% of the vision loss in children worldwide is with congenital cataract, and rest 1/3 is with congenital rubella, the cataract cause. Some are unknown and some are inherited. So this is the main in child. In adult, the ophthalmologic emergencies we can see, like acute closed angle glaucoma. Glaucoma, we know it's a common source of blindness, and there is increased pressure in the anterior compartment. And the acute closed angle glaucoma, it presents with severe eye pain. Along with the headache, the frontal headache, and it usually starts in the evening when the pupils have been dilated for several hours, like watching television in a dark room. So that is associated, the patient will say he or she is seeing halos. So that is also very important. And on physical examination, when we see the pupil is dilated and it does not react to the light, and the cornea appears cloudy, and the eye feels hard like a rock. That is very important. It feels hard like a rock because the build-up pressure inside and the secretion is not able to drain either through the trabecular meshwork or through the uveoscleral outflow, and that leads to the uh, fluid to be built up inside. The pressure it causes to the entire structures, that is also very important. That's why we go for emergency surgery to decompress the fluid which is trapped in the anterior chamber. And if we have to wait for a surgeon, what we can do, we can quickly administer carbonic anhydrase inhibitor like acetazolamide. It is a acetazolamide, and apply topical beta blockers and alpha 2 selective adrenergic agonists like mannitol and pilocarpine to decrease the fluid pressure. And now the next thing that we see in the emergency, very common thing, is orbital cellulitis, and it is also very tender, very red and swollen eyelids, and patient will have systemic signs. He will have fever, and the key finding is mainly that pupil is dilated plus fixed, and the ocular motion is very limited. So there can also be pus in the orbit. So we normally diagnose it clinically, and if we want to plan a surgery, then we have to do CT, and then we can go for the emergency surgical drainage, and also we'll give the IV antibiotics. Next thing, very common in the emergency, we see chemical burns of the eye, and which requires massive irrigation. And we start with the irrigation with plain water as soon as possible, and we do not wait for the arrival at the hospital. Then and there itself, we'll start with the irrigating the eye with the plain water. And once the eye has been opened and washed under the running water for about 30 minutes, then we can take the patient to emergency department, and there we can irrigate with the saline continuously, and corrosive particles are removed from the corners wherever from the eye. And before we send the patient back to their home, we have to make sure the pH is tested, so we are assured there is no harmful chemicals in the conjunctival sac. Next, very important, is retinal detachment. So it is also an emergency, and the patient will come with seeing flashes of light and floaters, and the number of floaters will give the idea. Like if it's more floaters, it's very severe, and it can appear like a snowstorm also to some patients, the floaters. And there is always a risk of detachment of the remaining retina, so we have to intervene in the emergency with laser spot welding, and that will protect the remaining retina. The next is that present in emergency is the embolic occlusion of the retinal artery. So this occurs typically in emergency in the elderly who describe there is sudden loss of vision, and in the one eye, and within 30 minutes the damage can be irreversible. And we ask patient first to breathe in the bag, and then we repeatedly press hard on the eye and release while the patient is still to be transported to the emergency. And to vasodilate, this we do to vasodilate and shake the clot, and the clot will go to more distal location, then a smaller area becomes ischemic and not the larger area. So that's why we keep on pressing hard on the eye and release while he is in transit. Now, some patient come with a newly diagnosed diabetics. They come for the eye examination because they have had it for years, the diabetes, but they are now coming for the examination, and the retinal damage already has occurred, and treatment is only to prevent the further damage. So we tell them about the any emergency that can occur and how to maintain the diabetic glucose and to prevent the blood glucose to go further rising, and antioxidants. So other thing that is very important, so these were the various emergency in the eye we studied about in children: amblyopia and congenital cataract, retinoblastoma. Those were very important to prevent the amblyopia post those defects. And in emergency we see glaucoma, we see cellulitis, we see chemical burns in the eye, we see retinal detachment with floaters, we see the retinal artery occlusion, and in chronic cases we monitor for diabetic retinopathy. Now, if there is acute glaucoma, so and mostly in the acute glaucoma, some are asymptomatic. So, but if it is symptomatic, then you have to go for carbonic anhydrase inhibitor that we already discussed, and topical beta blockers, and the alpha 2 selective adrenergic agonist. And in the case the patient has orbital cellulitis, then we have to go for CT, and we have to assess the extent of the orbital infection and begin the IV antibiotics. If there is a chemical burn, we'll do copious irrigation, and we ask the patient to pry the eye open under the cold water from the tap at home and irrigate for 30 minutes before coming to the emergency department. And we do more irrigation with the saline, remove any solid matter, and check pH before the patient is discharged. And in retinal detachment, there is more floaters, and there are cloudy appearance in the visual field. That is due to hemorrhage that is settling in the bottom of the eye, and for that we need sport welt and the retina and prevent the further detachment. And in acute embolic occlusion of the retinal artery, we will evaluate for a CVA, and we'll get the patient in the emergency, and we can give the patient aspirin and breathe into the bag, and we can press hard on the eye and release it repeatedly to dislodge the emboli and prevent the massive ischemia that can occur in the eye. So next we can see in the neck masses that we can, if we go down further, we see in the neck mass some congenital masses appear, some inflammatory masses appear, some neoplastic masses are there. So congenital, we talk about thyroglossal duct cyst, and it is around 1-2 centimeter neck mass, and it is located in the midline at the level of hyoid bone, and it mainly originates from the foramen cecum in the tongue. So when we pull the tongue, it retracts the mass. So what we'll do, we'll remove the we'll remove the mass, the cyst, and the middle segment of the hyoid bone and the tract that leads it to the base of tongue. It is called a cyst trunk procedure. So mainly we see examination, the cyst will move along with the deglutination as the patient swallow. The cyst also moves along with it. So it's possible that there is only sometimes thyroid tissue in the cyst. So we just remove it. And so what we'll remove the cyst along with the middle segment of hyoid bone and the tract that is leading till the base of the tongue. Next cyst, which is congenital, can be branchial cleft cyst, and it is laterally present along the anterior margin of the sternocleidomastoid muscle. Okay, here, and in front of the tragus to the base of the neck, and it is comparatively larger in diameter, and it has a punctate opening and a blind tract in the skin overlying, so we can remove it. Patient can also present with like the child can present with the pain and the wry neck sometime because of it. Now there is cystic hygroma that we discuss a lot. It is the from the name itself, it is lymphatic overgrowth malformation. It is made up of normal lymphatics, and it is found at the base of the neck, and it is very large and spongy. Like this is there, so this is very large and spongy, ill-defined mass, and it will occupy the entire supraclavicular area, and it seems to be extending deeper into the chest, and sometimes they go very deep into the mediastinum. So we have to do CT first of all to check the entire tract, and then we can surgically excise it. And now we know there are some other important inflammatory and neoplastic masses that we see in adults, like lymphoma. Very vaguely we are not going into type and pathophysical, no. It is like multiple enlarged nodules we will see in the neck or anywhere else, and the patient will come up with some fever, mild fever, night sweats. And when we do FNAC of the tissue, then we'll see it as a lymph node, and we can surgically remove it. And if we want to subtype the type of lymphoma, we can go for the flow cytometry, and we'll see the specific markers for every lymphoma, and mainly we can go for chemotherapy. There can be metastatic cancers that can spread to supraclavicular lymph nodes, and they come from the below the clavicle or below the clavicle, and some lung or intra-abdominal tumors can be primary cancer that lead to this metastatic lymph nodes getting positive, and biopsy of lymph node is done so that we can diagnose it as metastatic cancer. And mainly we say one specific name for Verco lymph node, and that is on the left side